morning everyone, respected judges. My topic is PRK in practice, real world visual outcome in 200 eyes. Introduction. Photorefractive keratotomy was the first excimer laser based refractive surgery introduced in late 1980s. Conventional PRK involved mechanical or alcohol assisted epithelial removal, which could prolong recovery and increase patient discomfort. To overcome these limitations, transepithelial PRK was developed. The advantages are non-contact all laser technique, faster and more uniform epithelial removal, reduced surgical time, less postoperative discomfort and alcohol toxicity. Although LASIK and SMILE offer faster visual recovery, trans-PRK remain highly relevant in patients with thin corneas, borderline topography, or increased risk of flap-related complication. Mitomycin C has further improved outcomes by reducing haze formation. The advantages, as I said, no flap cut, it's a touchless procedure, no risk of dry eye, no blades or cuts, good for contact sports, quick surgery, suitable for thin corneas and high myopia. The aim of a study to evaluate uncorrected and best corrected visual acuity after trans-PRK to assess refractive accuracy and predictability and to document postoperative complication. Methodology: this is a retrospective observational study conducted in 200 eyes of 100 patients over 1 year period. Inclusion criteria: age between 18 and 15 years, stable refraction for more than or equal to 12 months, myopia up to -10 diopter, astigmatism up to 4 diopter, hypertropia up to 4 diopter, adequate corneal thickness, clear cornea, and desire for spectacle independence. Exclusion criteria include keratoconus or form crest keratoconus, corneal thickness less than 480, severe dry eye or keratitis, prior herpes keratitis or uveitis, systemic contraindications. The patients were evaluated for visual acuity, cycloplegic refraction, anterior segment evaluation, posterior segment evaluation, corneal topography, IOP measurement, and dry eye evaluation were done. Surgical technique include after putting in topical anesthesia, single step PRK which ablates both epithelium and stroma, followed by mitomycin C application and irrigation with BSS. After that, bandage contact lens was applied. This is the surgical video. Topical anesthesia was installed. Then laser, followed by mitomycin C application, irrigation with BSS, and BCL was applied. Postoperative care: antibiotics were given for 2 weeks, tapering steroids 6 to 8 weeks, lubricants for 2 to 3 months, and patients were followed up on day 1, week 1, month 1, 6 months, and 1 year. We studied UCVA, BCVA, spherical equivalent refraction, corneal clarity, complications. Results: 76% were females and 24% of eyes were of males. Refractive error: 61% myopia, 37% myopic astigmatism, and 2% hyperopia. UCVA outcomes over time. In this graph, we can see from 1 month to 6 months, there is a steady increase of visual acuity, and at 1 year, 80% of the eyes achieved 6/6 vision, and 96% achieved UCV of 6/9 or more. Refractive accuracy at 12 months with out of patients less than 6/6 vision, 78% within plus or minus 0.5 diopter and 92% within plus or minus 1 diopter. Complications: severe pain within 48 hours, 40% patients experience severe pain, 5% of patients had corneal haze of grade 1 to 2, 3% had delayed healing, and 2% regression. Discussion of findings confirm that trans-PRK provide excellent refractive accuracy and stable long-term visual outcome. 96% of eyes achieved UCVA more than or equal to 6/9 by 1 year, and 92% were within plus or minus 1 diopter of intended correction. Transient postoperative pain was frequent but resolved within 72 hours. Mild corneal haze occurred in 5% of cases. Mitomycin C application helped minimize visually significant haze. Regression was minimal and observed primarily in higher myopes. No ectasia or sight-threatening events occurred, underscoring the safety of trans-PRK in carefully selected patients. Compared with classic trans-PRK, avoid flap-related complications and preserve corneal biomechanics, making it particularly valuable in thin corneas and borderline topographies. To conclude, trans-PRK is a safe, effective, and predictable refractive surgery in this series of 200 eyes. UCVA more than or equal to 6 by 6 was achieved in 80%, and UCVA more than 6 by 9 achieved in 96 percentage at 1 year. BCV was maintained or improved in 90%. Complications were minimal and transient. Trans-PRK thus remain a strong alternative in modern refractive surgery, especially in patients not suited for LASIK or SMILE. These are my reference. Thank you.
Thank you. So do you think 80% patients achieving 6.6 is a good outcome for any refractive procedure?
Sir, only some myopes, amblyopia patients were there. 85 patients had only preoperatively. BCVA was in only 85% of patients. 15% had.
You should have excluded those groups. Okay, because the data you are presenting, it appears transepithelial PRK is bad because if 20% patients are not achieving 6.6, a lot of these patients they do come for professional reason. Okay, if out of 120 people are not getting 6.6, that is not a good outcome for a refractive procedure. Okay, so you should have excluded those patients in which you were suspecting amblyopia, and then you should have given us a data key in this patient the refractive error was this and this. Okay, or else it's not good be a good picture. It looks like trans PRK is not good, not efficacious like LASIK.
Yes, sir.
Patients were trans PRK.
Yes, sir.
And mitomycin, what nomogram did you follow for the application of mitomycin?
So usually for one diopter 10 seconds. So
Okay, so you're doing 1 diopter 10 seconds. Sir said that number is, I mean, when you compare literature, right, and this abundance of data available for trans PRK doesn't correlate at all. 80% is not a good number.
Okay, 85%
Yeah,
were.
because you expect, no, most patients achieve 6.6 at 1 month follow-up. In fact, most patients achieve it by the 1 week follow-up itself. That's all. It's known data. It's already there in literature. Yeah. So just look at, there's a lot of things that you've included which have actually dumbed down your data, which makes it a problem when you present.